Welcome to Year 2, Module 3 of the My Mind Zero Suicide Trainings. As you probably know, I'm Leslie Johnson, and my pronouns are she, her, and hers. I'm so happy to continue to work with you on the goal of zero suicide. This training and the next one will focus on populations of patients who are at particular risk for suicide. While we want to be aware of risk for suicide for all patients under our care, we know that there are certain populations of patients who are at increased risk. For this reason, we focused on a few specific populations for today's training. Unfortunately, we're not able to cover all populations, but we do hope to cover more in the future. Before I get started, I just need to read this. Support for My Mind is provided by Blue Cross Blue Shield as part of the BCBSM Value Partnerships Program. Although BCBSM and My Mind work collaboratively, the opinions, beliefs, and viewpoints expressed in this training do not necessarily reflect the opinions, beliefs, and viewpoints of BCBSM or any of its employees. Here is our meeting agenda for our time together today. We're going to start with a discussion of the LGBTQ plus population and their suicide risk. This will include some glossary terms and a little bit on language, an important topic for this population. Then we're going to discuss service members and some of their unique needs for suicide prevention. Finally, we'll be talking about middle-aged men, a group with particularly high risk for suicide. By now, you've seen the suicide prevention care pathway for behavioral health quite a few times. We wanted to bring it back here because even though this is the care pathway for behavioral health, it shows the relative suicide risk for different conditions and situations. Since the writing is hard to see here, I'm going to have an enlarged version of the risk stratification slides when I use them. We're going to start our discussion with information on the LGBTQ plus population. LGBTQ plus stands for lesbian, gay, bisexual, transgender, and queer or questioning. The plus acknowledges that there are other terms that can be added to this. Sometimes you might hear LGBTQIA to include people who are intersex and asexual. There may also be a two for two-spirit, a term used within indigenous communities of North America. For today, we're going to use the term LGBTQ plus to cover people who fall into all of these groups. We're going to start with our discussion with a note on language. Language is an extremely powerful tool. It allows us to generate ideas, share stories, and learn and grow from others. Whether spoken, signed, or written, all languages are constantly evolving, and despite their imperfections, can help us better understand our world and communicate our perspective with others. This quote comes from the It Gets Better Project, a nonprofit organization with a mission to uplift, empower, and connect lesbian, gay, bisexual, transgender, and queer youth around the globe. This organization was created in response to the deaths of youths who are LGBTQ plus and who died by suicide after being bullied. It's important to know that many people who are LGBTQ plus use specific words to express themselves. This information can help those around them to understand who someone is and how they wish to identify. Some of these terms are used universally by people who are LGBTQ plus, while others relate to specific concepts like gender identity, gender expression, or sexual orientation. With that in mind, here is part of the glossary that came from the It Gets Better project. As providers, it's important that we're aware of and acknowledge the distinctions between these different terms. Gender expression is the external manifestation of gender, expressed through such things as names, pronouns, clothing, haircuts, behavior, voice, body characteristics, and more. The gender identity is one's internal, deeply held sense of gender. Some people identify completely with the gender that they were assigned at birth, usually male or female, while others may identify with only a part of that gender or not at all. Some people identify with another gender entirely. Unlike gender expression, gender identity is not visible to others. At birth, infants are commonly assigned a sex. This is usually based on the appearance of their external anatomy and is often confused with gender. However, a person's sex is actually a combination of bodily characteristics including chromosomes, hormones, internal and external reproductive organ, and secondary sex characteristics. As a result, there are many more sexes than just male and female, just as there are many more genders than just male or female. Sexual orientation is the desire that one has for emotional, romantic, and/or sexual relationships with others based on their gender expression, gender identity, and/or sex. Many people choose to label their sexual orientation while others do not. An ally is someone who supports equal civil rights, gender equality, and LGBTQ plus social movements, advocates on behalf of others, and challenges fear and discrimination in all of its forms. The chosen family is a group of people who are not necessarily biologically or legally related, but who play significant roles in each other's lives, providing unconditional and mutual love and support. Cisgender or cis is a person whose gender identity matches the gender that they were assigned at birth. Transgender or trans is somebody whose gender identity differs from the one that was assigned to them at birth. And coming out is the process through which a person accepts their sexual orientation and/or gender identity as part of their overall identity. Some EMRs support the use of these terms in patient identification, providing preferred name and pronouns in their demographic information. This can be built into the EMR in a way that the patient can even put that information in themselves. However, sexual orientation and gender identity questions are often left out of assessments. My mind recommends clear identification of these statuses to support improved care and suicide prevention. When you have a patient who identifies as LGBTQ+, it's important to remember that those who identify as such are at moderate risk for suicide with no other risk factors present. We know that patients who are LGBTQ+ are at higher risk for suicidal ideation and attempts, but the rates can be really staggering. Here you'll see from research completed in 2018 and 2022, it was found that a person who is a sexual minority is over 3 times more likely to experience a suicide attempt than a person who is heterosexual. In one meta-analysis, those who identified as sexual minorities also experienced suicidal ideation and behavior at an earlier age, experienced a greater desire to die in their most lethal attempt, and had a greater likelihood of a future suicide attempt than those who identified as heterosexual. It's important to emphasize that being LGBTQ+ is not putting somebody at higher risk by itself. It's that their identity is constantly being devalued, the feeling that they can never really be themselves. Another study found that even though younger members of the LGBTQ+ population enjoy more rights, they still experience minority stress and are at higher risk for suicide than older members of that population. As you can see, People who identify as sexual minorities are at markedly higher risk for suicide. And in the research, it appears that those who are younger and identify as a sexual minority are at higher risk for suicide than their older peers. This means that we need to be especially mindful of these patients who are younger and identify as LGBTQ+. The situation is even more dire for those patients who identify as transgender, with a lifetime prevalence of suicide attempts estimated to be between 32 and 41%, much higher than the average prevalence in the general population of 1.9 to 8.7%. We want to acknowledge here the high rates of trauma and violence in our LGBTQ plus population, as well as anxiety and hypervigilance that this population can experience due to anticipating possible violence. We recognize this here because this increases the suicide risk in this population, and it highlights the importance of creating a safe, accepting, validating clinical environment for our patients. When working with our patients who are LGBTQ+, it's important that we are aware of interventions that have been shown to be effective in reducing the level of risk for this population. Well, we know that for all patients, completing a safety plan, lethal means counseling, providing crisis resources, community support groups, and involving loved ones are the most effective risk modification tools. There are additional tools that have been shown to be effective interventions for the LGBTQ plus population. You'll see on the screen here specific interventions that research shows have been effective suicide risk reduction strategies for those who identify as LGBTQ+. Unfortunately, many members of the LGBTQ+ population face stigma and prejudice in their lives, and research shows that many of them end up internalizing these negative judgments. Decreasing negative self-evaluations and increasing tolerance of their negative emotions has been shown to be a protective factor for suicidal risk. Just knowing that the stigma exists and can be internalized will help you to better help your patients who are LGBTQ+. Behavioral health providers can work with patients to help explore and challenge negative self-evaluations with interventions like cognitive behavioral therapy. Another important risk modification intervention is to find ways for patients to connect to their local LGBTQ plus community. We know that having access to healthy supports and community resources reduces suicide risk for any patient experiencing suicidal ideation. But these connections have been shown to be particularly important and beneficial for our patients who are LGBTQ+. Working with a patient to explore areas for increased support is important and may be helpful for you, and it may be helpful for you to be aware of some local LGBTQ plus support groups that you can refer your patients to. Learning and practicing emotion regulation skills is another helpful intervention for patients experiencing suicidal ideation, and it has been shown to be particularly helpful for the LGBTQ plus population. There are multiple effective emotion regulation tools available that are easy to introduce to your patients. Teaching emotion regulation is something that our behavioral health participants would do, but we still feel it's important for primary care to be aware of the interventions that are shown to be most effective with our patients who are LGBTQ+. There's a handout in the My Mind Partner portal on emotion regulation for your patients in case you're interested. It has also been shown that upstream interventions can have a significant impact on the quality of life for the LGBTQ plus population. Marriage equality, anti-discrimination laws, and events like LGBTQ plus History and Pride Month have helped this population's visibility as well as their overall quality of life. With marriage equality and many anti-discrimination laws in place, it may be easy to forget that the Diagnostic and Statistical Manual of Mental Disorders didn't stop categorizing homosexuality as a mental illness until 1973. When we're thinking about equality, it's important to keep in mind some facts about rights for our patients who are LGBTQ plus and their loved ones. For example, the Movement Advancement Project tracks various aspects of democracy in the United States. Among the policies that they track are those that affect those who identify as LGBTQ plus. They rate policies affecting the LGBTQ plus population as high, meaning favorable, medium, fair, low, and negative. And according to their latest numbers, only 44% of US states and territories have a high to medium policy environment for the LGBTQ plus population, and 46% have a low to negative policy environment. 10% have a fair policy environment. Michigan has a medium policy environment. Michigan does have laws relating to employment and housing discrimination for the LGBTQ plus community. Note that now federal law prohibits discrimination in employment based on sexual orientation and gender identity. However, there is no federal protection for the LGBTQ plus community in housing, and there are a wide variety of laws in the country on this subject, creating a confusing patchwork of protections. In one study involving 3 cohorts of people who identified as sexual minorities, the youngest cohort, born between 1990 and 1997, came out much earlier than those in the older cohorts, those born between 1956 and 63 and born between 1974 and 81. Researchers suggested that gains in equality had a positive impact on this cohort. However, the youngest cohort also showed the highest level of psychological distress and suicidal behavior. This shows that we still have a long way to go for this population to feel truly equal and comfortable in society. Another point is that we all know that the chemistry ups and downs in adolescence and young adulthood are already so intense. Then adding in another layer which makes the person feel different all the time can make that time even more intense. The study also indicated, regardless of the political climate, for many sexual minority youth, acceptance at home, in school, and in religious communities is still unattainable. Additionally, studies have shown that even after marriage equality was passed, minority stressors still persist for same-sex couples, particularly in the familial domain. So how else can we support our patients who are LGBTQ plus? Well, we need to be aware of these national statistics and upstream impacts we can advocate for. We all also know that starting with small, respectful interventions in our clinics is an important first step. As we've seen, one important thing we can do is to be aware of the language that we use when talking to our patients. Offer your pronouns and ask for the pronouns of your patients. Consider making small changes, such as regularly using the term partner as opposed to husband or wife. And it's important to be mindful of assumptions. Remember that just because someone is married, that doesn't mean that they're in a heterosexual relationship. Another thing to consider when treating the LGBTQ plus population is the trauma that they may have experienced and the need to create a safe environment for them. It may also mean that patients who have experienced trauma need additional time to become comfortable with us as their providers. As providers, we can advocate for larger upstream interventions while also implementing small daily practices in our clinics. Next, let's think about the case of Jesse, and I'll be asking some specific questions related to his care. Jesse is a 23-year-old transgender male who uses he, him pronouns and is in his last year at a local university. He scored a 2 on the PHQ-9 question number 9. You discuss this with him and you learn that Jesse has suicidal thoughts but no plan. Jesse's sister is important, but he has limited social support and notes that he feels alone at his university. Reviewing a past safety plan, you notice that he had previously listed multiple healthy coping skills and hobbies he enjoys, but he does not have many people he can talk to for support. And during your appointment, Jesse shares that he does not feel supported by the general community. Jesse is hesitant to review and update his safety plan during his appointment today. So think about these questions. Do you know of any supports and resources available in your area to further support someone like Jesse? How do you share these resources with your patients? Thinking about your clinics specifically, are there any steps that you take at your clinic to ensure inclusivity for people that are LGBTQ+? And are there any steps your clinic takes to ensure inclusivity for all your patients? Thinking back to Jesse's case when he was hesitant to update the safety plan, if someone is resistant to completing or updating a safety plan, what steps do you take to engage them? Now, in Jesse's case, he doesn't need to go to the ER today. But one thing to keep in mind is that amongst the general population, going into the ER can often increase suicide risk after discharge. For people who are transgender, a trip to the ER can increase this risk even more. It's important to leverage interventions like involving loved ones, safety planning, and lethal means counseling and removal in this population to ensure that they have as many robust supports as possible to keep them safe. Next, we're going to discuss veterans, another group that is at particular risk for suicide. This group is also at high risk for suicide by firearm, which we'll be discussing in more detail in the coming slides. We're focusing on our veterans here due to the unfortunate rise in rates of suicide amongst our service member population. There are about 20 million veterans in the United States, about 18.9 million men and 1.8 million women. While veterans seek care at the VA, we also treat many veterans in our own practices. It's important that we always ask patients if they served so that we are aware of whether they're veterans and then can be aware of their elevated risk for suicide just for having served. This is important as not all clinics track this information. My mind recommends tracking statuses like this for improved care and suicide prevention. You can see here that service members, whether active duty or veterans, are at moderate risk for suicide with no other risk factors present. However, you can see the other things that can put a service member at elevated risk for suicide: chronic severe pain or multiple chronic medical problems. The nature of service member duties puts them at elevated risk of having injuries that can cause severe pain. They're also at risk of having multiple chronic medical problems caused by these injuries. Traumatic brain injury is also a concern with this population. First, we're going to take a look at some of the statistics surrounding suicide rates of our veterans. A study completed by the VA found that veterans constituted 8% of the 2018 United States adult population and 13.8% of suicide deaths. Firearms are used in 73.5% of veteran suicide deaths compared to 52.2% among non-veterans. If you're interested in learning more, the National Strategy for Preventing Veteran Suicide 2018 to 2028 is available to everyone and has some statistics, including that an average of 20 veterans die by suicide each day. About 6 of the 20 are recent users of Veterans Health Administration services. Rates of suicide were highest among younger veterans, ages 18 to 29, and lowest among older veterans, ages 60 and older. Despite comparatively lower rates, the largest number of deaths by suicide is among middle-aged and older adult veterans. Approximately 65% of all veterans who died by suicide were age 50 or older. And this is because the total number of middle-aged and older veterans is higher. The VA published the National Veteran Suicide Prevention Annual Report in December of 2024. This report reflects the larger strategic plan outlined in the National Strategy for Preventing Veteran Suicide 2018 to 2028. Unfortunately, the 2024 report shows some troubling patterns among our veteran population. 73.5% of veteran suicides were by firearm. That's an increase of 7.1%. Firearm suicide rate among male veterans was 69.6% higher than non-veteran males. Firearm suicide rate among female veterans was 144% higher than non-veteran females. But there is some good news. From 2021 to 2022, female veterans saw a 24.1% decrease in age-adjusted suicide rates. In 2022, the number of veteran suicides was lower than in the past 12 of 14 years. We met with representatives of the Veterans Administration for their insight, and they indicated that service members who are women tend to use firearms for suicide, the most lethal means for suicide. We have a long way to go to care for those who served our country, but thankfully there are steps we can take today to support these patients. In our meeting with representatives from the VA, they described the following characteristics of service members. They lived, slept, and ate together during their service, often under hazardous or uncomfortable conditions, and they often find themselves seeking connection once out of the military service. Encouraging and helping service members find areas of connection and support is an important step in risk modification for these individuals. During their training, they were also taught to push through discomfort, which makes it difficult for them to ask for help if they're suffering. As providers, we need to be aware of this tendency and not be afraid to probe a bit when working with any patient, but especially our veterans. Take some extra time to check in with them on their physical and behavioral health symptoms if you're getting responses like, "I can handle it," or statements minimizing their symptoms. Ask some follow-up questions to dig a bit deeper into how they may be feeling. Many service members are also attached to their firearms. The VA representatives pose this in a clear and straightforward way. For many of our veterans, their firearms are seen as the means that got them home safely from combat, which brings an attachment to them. Lethal means removal can be difficult with veterans and needs to be approached with this in mind. We want to respect their time in the service and their attachment to their firearms while also discussing any acceptable method of risk modification that they will agree to. Lethal means removal is always the preferred option, But if a patient does not have a plan or intent and is open to any form of risk modification, that is acceptable. We'll discuss this more in just a couple slides. Veterans can also have an array of combat-related injuries or training-related injuries, like chronic back pain from carrying heavy loads over rough terrain. Research shows us that any individual with multiple medical comorbidities is at higher risk for suicide, so these medical symptoms also raise our veterans' risk for suicide. One final thing that the VA shared with us is that oftentimes veterans see value in the chain of command, and a provider may be viewed as an authority figure. This is just something for all of us to be mindful of, and as I'm sure you do, it's important for providers and staff to approach veterans with respect. Along with the considerations discussed, research also shows that there are 3 interventions that are particularly helpful in risk modification for our veterans, which are carrying cards and follow-ups, peer supports, and safe firearm storage and/or means removal. One small study showed that veterans who called the VA crisis line found carrying cards and the resources that they contained helpful, and the opt-out rate for the carrying cards was extremely low, less than 0.1% of veterans receiving them. This is important because this study also indicated that callers enrolled in the VA have high rates of suicide within 1 month of the call, and the rates will remain elevated through a year after the call. So an intervention like sending caring contacts is very important for all patients, but especially for our veterans. Peer supports have also been found to be helpful for service members. Many service members have found value in the shared experience that peer supports offer. They are also a great social support, especially to those who are socially isolated. And safe firearm storage is a must for veterans, since 73.5% of service members use a firearm for suicide. And remember, even if somebody isn't in crisis, homes are safer when firearms are safely stored. As a review, here are some home-based storage options with varying levels of cost. Cable locks, gun case, lockbox, electronic lockbox, and full-size and biometric gun safes. Some important facts to keep in mind when discussing firearm removal with patients are: some firearm owners believe that they can't quickly access a firearm that has been secured by one of these methods. However, safe storage options such as lockable cases can be quickly accessed while still reducing access by those who are unauthorized. Hiding a loaded firearm in a closet, drawer, or similar area does not secure it, and people in the household generally know where the firearm is hidden. Research shows that suicide risk can be reduced by storing the firearm separately from the ammunition. Thinking that someone in crisis will find another way to harm themselves if the method that they're thinking of is not available is a myth. Remember that the acute risk for suicide is often short-lived. When one method is not available, most people don't switch their method. If you can help someone survive the immediate crisis by keeping a firearm safely stored, then you've gone a long way toward saving their life. Research shows that the majority of people who survive a suicide attempt do not die by suicide later on. Remember that firearms are the most lethal means for suicide. 9 out of 10 people who use a firearm for suicide die. Dr. Amadani, our co-director in researching suicide worldwide, indicated that rates of suicide by firearm is a problem unique to the United States. So taking any of the above steps is going to make people safer. The VA, in collaboration with Psych Armor Institute, developed the SAVE online training video, which describes how a family member or other support person can act with care and compassion if they encounter a veteran who is in suicidal crisis. The training has 4 lessons, and there is approximately 1/2 hour of video content. It has 4 steps. S, recognize the signs of suicidal thinking. A, ask the question, are you thinking of ending your life? V, validate the veteran's experience. And E, encourage treatment and expedite getting help. The direct link is on the slide. Another resource we want to make you aware of is the Compact Act. At no cost to them, veterans experiencing acute suicidal crisis can receive immediate medical care at a non-VA facility. The Compact Act was developed to reduce veteran suicide by expanding access to cost-free care. Veterans can call 911 or go to the nearest emergency room when in crisis. The VA will provide treatment or cover the cost for treatment. Veterans do not have to be enrolled in VA healthcare. Providers or the veteran patient needs to call 1-844-724-7842 as soon as possible, preferably within 72 hours, to advise the VA of the admission and start the approval process. The VA will cover all mental health related services for the veteran for up to 90 days. Extensions can be granted for veterans needing care for a longer period of time. This coverage applies to inpatient or crisis residential care and can even apply to some outpatient care if the patient is identified as being in a suicidal crisis. Be aware that programs through the VA may change with funding or other system changes, and you may need to contact the national number, 1-877-881-7618. Now we're going to review the case of Dana, a female veteran in her 30s who did 2 deployments in the Navy and who was honorably discharged. She scored a 2 on PHQ-9 question 9 and 24 overall and has firearms in her home. She's attached to her firearms because of her time in the military, but also because she feels they keep her safe in her home. She has a very supportive husband and 2 younger children at home who she loves dearly. Dana shares with you that she would never kill herself, but she also feels depressed every day and often doesn't want to be here anymore. One thing to keep in mind about service members is that while they may not receive their health care through the VA, they may receive their medications through the VA. So a thorough medication assessment is important. You may be able to see this information through your START charting system. However, this might not always be complete, and it's still important to ask. Now we're going to, again, take some time to think about care for Dana. First, how would you approach the lethal means discussion with Dana? What are your biggest barriers with discussing firearm removal with veterans and others who are attached to their firearms? Do you have any best practices that you use with lethal means counseling? And do you have any resources or local supports that you can leverage during these conversations? Do you have any resources that you provide specifically to the veterans that you treat? You know that some of the statistics you saw today regarding veterans and suicide risk may have felt overwhelming. The good news is that there are interventions that we can take today to help protect our veteran patients. We also want to share some specific resources from the Veterans Administration handout, Safe Home Environment. These will all be available in the slide deck. Here are some more resources from the VA handout Safe Home Environment. Also, for family members, there is the Suicide Prevention Toolkit for caregivers available at the link on the slide. This next population that we discuss may seem like a broad group. However, we feel it's important to recognize that currently middle-aged men comprise a significant number of suicide deaths in the United States. Middle-aged men are also at particular risk for using a firearm in the suicide attempt, which is a factor in their risk level. We're going to discuss more about this in the coming slides. Well, there is not a firm age range for what is considered middle-aged. Most sources indicate that it occurs somewhere between the ages of 40 and 60. In the LGBTQ plus and service member populations, younger people were at higher risk for suicide. However, in general, middle-aged men comprise a surprising and significant group of people at risk. And Caucasian men are at particularly high risk. While women are more likely to attempt suicide, men are more likely to die by a ratio of 3 to 1. And this is because men use firearms for suicide more often than women outside of the women who are service members. When we look at middle-aged men, there isn't a large amount of research on the risk factors for this specific population. However, in a large British study, they found that the following characteristics of men who died by suicide within 3 months after seeing their primary care physician. They suffered a major physical illness. They had a history of recent self-harm. They experienced work-related issues. They experienced mental health problems. One older study indicated that middle-aged men who are divorced, widowed, or separated are at higher risk for suicide. Our content experts also noted that lack of meaningful relationships also can contribute to suicide risk. It's important to be aware of these major life changes and how they impact all of our patients, but it's particularly important to be aware of these risk factors for middle-aged men. Middle-aged men as a group do not appear specifically on the zero suicide care pathway. However, given that the last study indicated that risk factors for suicide include major physical illness, recent self-harm, and mental health conditions, it's clear that they can be at risk for suicide for a variety of reasons. And while I will cover this in more detail in the next slide, since middle-aged men don't seek care often, they could have a variety of undiagnosed illnesses. Given their propensity to use firearms for suicide, the most important intervention for middle-aged men is lethal means counseling and removal. This can be a challenging topic to bring up as, like we discussed with our veterans, many individuals are attached to their firearms and feel safer with them, but it is important that it be discussed. Safety planning is also important. One study found that patients who visited the emergency department for suicide-related concerns and received safety planning and follow-up calls were half as likely to have suicidal behavior and more than twice as likely to keep follow-up mental health appointments as those who did not receive those interventions. While this study was on veterans, it's important in the discussion of middle-aged men as the mean age was 48 and the participants were 88% men. Another reason that caring cards are so important is that these patients tend to be isolated, especially those who are separated, divorced, or widowed, and a caring card can help them feel connected. This will also help them to attend future appointments. According to our director, Dr. Amadani, middle-aged men tend not to seek care often. This is why it's important that once they are in the clinic, that they keep their follow-up appointments. Caring cards can go a long way in helping to make this happen. The British study that I cited earlier also indicated that men on psychotropic medications were more likely to die by suicide within 3 months of seeing their primary care provider than those not on those medications. Even patients who have been stable on these medications can destabilize at times because of work issues, loss, or other stressors that patients have been experiencing. This is why it's important to continue screening every patient every time. Just because someone was stable and managing their behavioral health symptoms well last month does not mean that something couldn't change and cause new onset of suicidal ideation. Now we're going to think about the case of Gerald. He's a 49-year-old Caucasian man who had a history of anxiety as well as chronic back pain and hypertension. There are layoffs happening at work, and he's worried that he's going to be next. He scored a 3 on question 9 of the PHQ-9 and 14 overall. His score on the GAD-7 was significantly high. He has adult children, but would never tell them what he was experiencing. He's divorced from his wife. He says he thinks sometimes it would be easier to be dead because of the job stress and continued back pain, but he's adamant that he does not have a plan or intent to die by suicide. He does attend church regularly, and he's involved with his church group. He has a firearm that he uses for hunting, and he's an avid hunter. Now let's take a moment to think about risk modification for Gerald. How would you approach discussing lethal means with Gerald? What other interventions would be helpful to Gerald? What barriers do you have for risk modification with Gerald? And what are Gerald's protective factors? Here are the key takeaways from this presentation. Language is important for the LGBTQ plus population, and using preferred name and pronouns shows respect for the patient. Clinic level and upstream interventions are both significant in decreasing suicide risk for the members of the LGBTQ plus population. Veterans seek connection. Community and peer supports can be vital in decreasing suicide risk. Veterans can be attached to their firearms, and clinicians need to be sensitive to this when counseling on lethal means. Caring contacts can be a valuable intervention for both veterans and middle-aged men. Lethal means counseling and removal are essential interventions for both veterans and middle-aged men, given their likelihood to use firearms as lethal means. Here are our references. You can always access them on the slides. And remember, if you're experiencing emotional distress or thoughts of suicide and need support, you can call or text 988. When we're caring for others, it's easy to forget that we can be struggling ourselves. So remember to check in with yourself and access the resources for yourself if you need them. You can always reach me at the email here if you think of any questions for me. And remember that while your PDSAs aren't due until May 1st, you can always complete them earlier. The portal is open. Thank you again for joining the training today and talking through these patient populations. Have a great day, and thank you for attending the My Mind Year 2 training, Special Populations Part 1.